All right. So this is a patient we saw back in June. So she's a 47-year-old female, sorry. And when she presented to the clinic, she was laterally dislocated in her patella. Um, so we got X-rays that day just to reveal that as well. But she mentioned that there was an incident uh, a couple weeks prior to her appointment where she was walking in Target and she just slipped on a wet wipe and like slipped into a lunge position that caused her to laterally dislocate. And then from that point on, she was having patellar instability on a day-to-day basis. Anytime she would get up from a seated position, anytime she would roll over in bed. Um, and I guess the most unique part of this case is 2 months prior to this incident, she had a patellofemoral arthroplasty. So yeah, she had an implant of the patella and of course, like the trochlear. And I guess backstory on that, she underwent that procedure just because she was having chronic patellofemoral pain, and her radiographs presented evidence of osteoarthritis of the patellofemoral joint specifically. Um, but she also had a lifelong history of patellar instability. But when she was first seen to get this arthroplasty, it was mostly to address her pain. Um, so
Um, so was she like, you say she has a history. So what do you mean by history? Like, was she an athlete in this, instability then, or was it just throughout her whole life, from childbirth,
so
another incident?
according to her, ever since she was a teenager, she was dealing with instability. But I don't think there was any history of her being an athlete, and she's also sedentary too. So um, I can keep going to kind of like because there's she obviously like she came to see us multiple times,
Yeah.
so I can keep talking through what we did. Okay. Um, so of course, I mean, she came into the clinic dislocated that day, so we relocated her, and we also gave her a lateral J brace. But because of the implant that she got 2 months prior, we wanted to kind of see if there's a issue with like the component of the components of the implant itself, and if this was contributing to her patellar instability. So we went ahead and ordered a CT scan. So we ordered that, and then she was going to follow up after getting those results. And when we got that CT scan, we found out that her surgery was done correctly. So she underwent a great surgery for the arthroplasty itself. But the CT scan revealed that she had a TTTG rating, measurement of 25 millimeters, meaning measurement from the tibial tuberosity to the trochlear groove, uh, just meaning like she was that far lateral. And I think a normal reading or normal measurement of TTTG is around 15 to 20, but her patella naturally sat like that far laterally. Um, so because of this, she was indicated for a tibial tubercle transfer, and also a combined uh, MPFL reconstruction. So we performed that back in August. And after the procedure, she also had a reaction to the sutures we used for this procedure, kind of almost like an infection. So we had to perform an irrigation and debridement and also prescribe her antibiotics afterwards. Yeah, it's a mess. This is why it was my case study.
I see that. Wow. Okay.
Yeah. Um, but today she's doing fine. She's ambulating without a brace. She's still going to PT, still working on quad strengthening. I mean, she complains of, anterior knee pain, quad weakness, but all that will hopefully come back to her. But yeah, I mean, definitely tough. She had the patellofemoral arthroplasty back in April, and then we had to perform an MPFL reconstruction with the TTT back in August.
So how much was the original surgeon involved? And if they weren't, would you have yourself seek them out, knowing what you do now?
So as far as him being involved, he once he found out that she was like chronically, like she was having like those instability issues that came up after the arthroplasty, uh he was concerned that it was like more so a soft tissue thing. So he was just concerned that the MPFL was compromised. So that's why he referred her to our surgeon, Dr. X, who performs MPFL reconstructions, tibial tubercle transfers, things like that. The previous doctor is a joints doctor. Um, so he was thinking the instability was due to her MPFL. So he referred her to us. And then what was the second part of that question? I'm sorry.
I was just saying, if they weren't involved, would you have, what would you want from them now? But it sounds like they were decently involved in the
Yeah.
case.
Yeah, the only question I would have for him, and I brought this up during my case study presentation as well, is if she had like the long, like, lifelong history of patellar instability. I just wanted to know why that wasn't addressed as well. But I also understand, and what was explained to me about other surgeons is, the fact she also has some other conditions such as like fibromyalgia, which contributes a lot to her pain. So the fact she has that, and she's sedentary, she's middle aged, uh, they were thinking, undergoing like a arthroplasty combined with like a tibial tubercle transfer and an MPFL reconstruction would have been like a really, really, really tough recovery for her. And I guess given the fact that, she's not an athlete, so it's not like she is like, doing any like side to side lateral drills or like movements like that, maybe she would do fine with just the arthroplasty to address her pain, which was her main complaint, but she always had the patellar instability. So.
How is this case specifically, besides, you know, having all these complications come up throughout, how is it, do you think it's challenged you as a clinician now to, if you come up with this again?
Ooh, that's a good question. I mean, I guess it would just challenge me to really like look into history, because I mean, knowing the fact that she's had lifelong patellar instability is a big, that's something that's important to this case itself. And then also the fact that she has fibromyalgia, which I mean, she's just gonna be like way more sensitive to pain compared to other patients. So knowing that could go back into the fact that why she didn't undergo like a bigger procedure at the time, and why the initial procedure was to address her, her arthritis, but also, her pain that she was in, because she was in really severe pain, which is the reason she got the knee replaceable, the patellofemoral replacement initially. So just really delving into the history, just knowing about what other conditions that they have that could contribute to their status right now and their condition right now. History is so important.
Yes, it is.
Yeah.
So what sort of precautions did you put in place? I don't know if you necessarily evaluated them or your physician did, but what sort of precautions were put in place to not increase the patient's pain due to fibromyalgia?
I really think it was so it's kind of hard just because like surgery is going to be painful regardless, especially a tibial tubercle transfer. So I think the precautions that were put in place initially were just undergoing just the patellofemoral arthroplasty. But I mean, with all our patients, we prescribe, pain medications, like we prescribe narcotic like oxycodone. But we're really like, obviously, because it's narcotic, that's something we don't want to refill a prescription on. So as far as pain, sometimes it's just one of those things where it's like there's no like easy way out of it, unfortunately. We provide the medications, because we anticipate they're going to be in a lot of pain, but we also don't want them to be too reliant on the pain. And then also we have other, some our surgeons that we work with, some of them have different methods when it comes to prescribing medications and different belief systems. Like Dr. X specifically is not one to like, he does not like prescribing narcotics. So even for like our meniscectomies, he just prescribes Aleve and Tylenol after. But some of our other doctors prescribe, oxycodone, Percocet. So I guess the biggest thing Um, just we were just really mindful of the fact that she had the fibromyalgia. So again, the first procedure was to address her pain initially. If we weren't like as I guess sensitive or like caring about her pain, I think we would have went ahead and performed all the combined procedures to address her instability and her arthritis.
Besides mostly trying to help her with her pain and everything, what is there like another did you ever think about trying to involve like a mental health component or any other part of maybe her rehab that could be affected, not just her pain, but another part of her life that may be impacted by all these instabilities and procedures?
That's a really good question. And unfortunately, I don't think we may have like specifically addressed the mental health aspect of this. I would like to think that every time like our doctors and us, when we think about, the procedures that we're consenting our patients for, that we're really thinking about like their outcome after, which we always do. And we understand when you undergo surgery, it's going to be a tough physically and mentally on the patient, but we always do that with the belief that, in the end, after like they climb up this like uphill battle, like they're going to be better. So um, that's kind of like how we look at things, because I mean, we just kind of look at what they want to get back into afterwards. For her, I mean, it wasn't even like activities that she wanted to get back into. It was just like, can I exist on a day-to-day basis without having this knee pain? And then after that surgery occurred, it was like, can I live on a day-to-day basis without, having my patella dislocate? Um, but I do think that can be underlooked. And especially in our setting, sometimes when we see so many patients on a day-to-day basis and we have limited time, well, the doctor will come in the room for like, just a very short amount of time to see the patients. I think sometimes this can be underlooked. Um, so, I mean, I guess just going back to answer the question, us just considering like what the outcomes would be for her and what would be best for her in the end, that's a part of the mental health aspect of it, because we just want to make sure she's back to living as pain free as possible on a day-to-day basis. And we know that living with chronic pain can affect your mental health as well. But I do think we could do a better job of screening for mental health. And also I mean, we have surveys and we have patients like answer these surveys regarding mental health, but I think uh, the doctors and us as athletic trainers could do a better job to gauge that. um, my personal experience so far, like in this setting, like there's only been like one time where I was like, oh, this person is like actually like clinically depressed and she's having an episode and she's venting to me right now about like all her life problems. So I tried to be like as supportive as possible. And then, I mean, I got good feedback from it. And she was actually like a family friend of one of our surgeons. And she was like, yeah, no, I really like this guy, which is cool. But I mean, I guess just, trying to be an active listener and just trying to be there for the patient. Uh, that's something that we can all do. But I think overall, we could have done a better job addressing this patient's mental health in particular.
So I know you talked about her seeing a physical therapist for, I think you said quadricep strengthening, correct? Have you ever thought of possibly taking into outreach to other things like maybe an occupational therapist? Because if she's having like issues around her day-to-day living, could that be maybe something you would see beneficial for her, or not necessarily for this patient?
That is a good question. Just because sometimes I wish I was like we would collaborate with occupational therapists more, but um I think it was still the best idea for her to just undergo regular physical therapy, just because there's just some things that you need for like the best outcome and recovery. And for her, especially when you have patellar instability and you have a surgery to correct this, I mean, quad strengthening is such a big key part of that. Um, Dang, the last time I was around an occupational therapist was like when I was a senior in high school and we had clinical rotations with them. I feel like in that, and again, this is like 6 years ago, such a long time ago. But I feel like like with patients that were seeing occupational therapists, they were literally like practicing activities that like, oh, like let's practice like reaching, up in the cabinet so I can grab things or this, like, things like that. I think, I mean, besides the fact that she was immobilized, which was a big part of it. I mean, we had to put her in a neomobilizer after surgery, which also inhibits, her activities of daily living, her capability to be functional on a day-to-day basis. I don't know how much an occupational therapist would have benefited more, or how much she would have benefited more from seeing an occupational therapist versus a physical therapist.
Mhm.
Um, I think if she would have done like a full formal course of physical therapy and she was still, not seeing results, and she, like everyday tasks just around the house were really bothersome to her, or like she was not functional at all, I think then maybe an occupational therapist would have been more indicated for her. But I think it was still a good call for her to just go like a regular course of physical therapy. Just because although like, considering her conditions, the fibromyalgia, the fact she's sedentary, um, those are going to inhibit like her recovery process, but she was still making progress nonetheless.
Is there anything you would necessarily, you've kind of touched on it a little bit, but you yourself would have done differently?
I'm trying to think. So it's funny because the first time I actually talked to this patient, so like when I chose this patient as my case study, I was reading notes from like some of my preceptors because they saw her back before I was even like in the program. So the first time I actually interacted with this patient personally was the day of her surgery. And I kind of went over like her post-op medications, fitted her in like her immobilizer, and then actually like helped make the the graft. But I guess what I could have done personally is called her more often. I know when she was having the infection issues after surgery, I mean, she reached out to us, and I mean, I, made sure to ask, like what symptoms she was dealing with. I had her send pictures to us so we can inspect the incisions, and then presented them to our surgeon. And then we got her in the next week to prescribe her some antibiotics. But unfortunately, we just had to go in there and clean up the incisions themselves. Uh, yeah, I think I should have called her more often, honestly. That would have been my thing. I called her a few weeks ago because she hasn't followed up with us in a while, and even like on our end, even our doctor was like, "Oh yeah, no, she should have followed up with us, or she should have an appointment scheduled." And I saw she had nothing scheduled, so I was like, "Oh, that's not good." So let me call her, reach out to her to see to see how she's doing. But I guess me personally, just checking in on her more, and just seeing how she's doing. A lot of patients. I mean, you can tell when you just like obviously like we're in this profession because we genuinely want to make a difference and care about patients, and we want to give people better outcomes. So when you just reach out to them, and even if it's not like a formal appointment that they're being billed for, if you just reach out to them and just, hey, how are you doing, like how's PT doing, how's your recovery, how's your day-to-day life now, after surgery, I think they really see that and they really appreciate that. So I could have been I could have reached out to her a little more if I say so myself.
Um, that was one of my main points I was going to ask with what Aaron just asked. So I guess I'll go off of if you were to come across something similar, or you see a patient that is having so many issues, what do you think you'll do differently from here on out?
Um, I guess for those type of patients, you would have to nuance like your approach. Like you can't when you're doing evaluations, or even like obtaining a history for a note, like you have to know the demographic. So for her, I mean, she's a middle-aged woman with all these conditions. She's not an athlete, so uh, when you're asking her questions, things like that, you just have to think about things that she would, activities that she would do normally, compared to like something that, some activities that an athlete would want to get back into. And again, for her, it was just to get back to pain-free activities of daily living. So I think I would just try to be more mindful of that when I'm asking her questions. And then, I mean, you always want to be respectful, no matter who your patient is, but just definitely having a focus on that as well. And then really considering, like, I guess considering, what they have to lose and what they have to gain in the situation. Like, I mean, this patient, like, she has she has a husband, she has kids, like, she has to eventually, she has to get back to taking care of her kids and, being there for them. So it's kind of tough when you're immobilized after surgery or in pain and maybe a little inebriated off the pain medications we've given you. Like, these are all things you have to consider. So just being really nuanced and optimizing like your treatment plan based on the patient's demographics. That's something I could work on more.
Okay, I don't have any more questions.
Yeah, we basically covered all mine too.
Yeah.
Do you have any questions for us? Or anything?
Well, great questions because y'all really made me think. And these are things that I really have to self-evaluate now, which is good. Yeah, no, I mean, I think this was a great discussion. At first I was kind of worried about like bringing this patient up because I mean, I know it's like, you guys work in secondary school settings, so I mean, this patient, like before this program, I would have been like, what? Like this, it's a middle-aged woman that has fibromyalgia and just had a patellofemoral arthroplasty, and now she has patellar instability. Like, how do you address this? How do you even like approach this?
Mm.
But no, you guys, ask great questions. I don't know. I don't have any questions. Great job. I mean, great talk.
Thanks.
Well, thanks for meeting with us.